Saif Lalani is one of our directors. He's an active member on the board. He has an interest in the research field and along the way has obtained 3 accounting designations in 3 different countries. He now manages his own accounting business here in Calgary alongside his lovely wife who's also on our board. Saif will be talking to us about recent advances in prostate cancer treatment. And with that, let's welcome Saif.
So Brad introduced me really nicely. It was a bit of a short introduction. I expect a little bit more poetic stuff, but he stopped pretty soon. So he mentioned that I have 3 accounting designations. Accounting was my second field. I switched. So I got a PhD in microbiology. So I have some interest in science, and I keep reading up on stuff. And so today we're going to talk a little bit about the recent advances in prostate cancer treatment. Now, what I'm going to talk to you about is solely my opinion based on what I believe the field is going towards, reading the papers that are out there. That may or may not necessarily translate into something very successful down the line, but these are the things that look like over the last year to year and a half that we are making big progress in. This content is not intended to be a substitute for professional medical advice. We have Google for that. And outside that, please consult with your physician on all matters. It's too cold for you, Brad? Too loud?
Too loud.
Too loud, okay. So a little bit about this dangerous guy we keep talking about. Prostate cancer is still the #1 killer at this point, and it's actually the gap between prostate cancer and the second highest cancer-related deaths is actually increasing over time. The simple reason for that is people are smoking a lot less. So we have a lot less lung cancer, which used to tower over prostate cancer a long time back. The other reason is people are living a lot longer, and prostate cancer is more of a 6th and 7th decade cancer than an earlier one, so we're getting more of that. And the third reason is we become pretty good at detecting it. So, this one study which recently showed that about 30% of people who died in their 80s had undiagnosed prostate cancer. So they had something else, and they didn't even know that they had prostate cancer because it's so slow growing in their case. So there's a lot of, we becoming better and better at finding it, and so some of the recent increases to do with that. Well, alongside finding it, we become pretty good at treating it also. So if you see the progress over time, when we first had some ways of treating it in 1975, which is a good benchmark when, we had something to treat it with. At that point, we had a survival rate of around 70%. And since then, that has dramatically improved. The last set of statistics we have for a 5-year study, which is 2012, and that was greater than 99%. And that obviously gets better and better. We're in 2019, so those people who are exposed to the 2006, 2012 treatment regimes, things have become a lot better now. And so what are these traditional treatments? So the main traditional treatment is surgery. We try to catch the prostate cancer as early as possible and get it out completely. Alongside, you have some more minimally invasive surgeries and robotic surgery, which essentially are trying to do the same thing but with less collateral damage. We have brachytherapy, cryosurgery. Again, those are some modalities of getting just the tumor out. To treat it outside the prostate, we have hormone therapy, which is the mainstay, which has been the linchpin for many years now. And in the last 5 years, we've got some additional tools beyond the hormone therapy. And there's active surveillance. This is a bit of a controversial area. It's been used successfully, and there's some papers out there for people with low-grade, slowly growing prostate cancer that we're just basically doing surveillance and not doing anything. So again, it goes back to that thing that we are finding people who are, we are doing autopsies on them in their 80s and they have undiagnosed prostate cancer. So how did that happen? Didn't even go anywhere. It just stayed in the prostate. It didn't even become so much that it could be detected within the prostate. So there are some kind of low-grade tumors there, and for that, some physicians recommend active surveillance. But it's controversial because most people's mentality is if there's cancer, go and get it out. Nobody wants that active surveillance thing. A little bit about the timeline of treatment. So when it's castrate sensitive, by castrate sensitive means it's reacting to hormones. It's sensitive to blocking that hormone from providing it food. At that point, you do local therapy, which is in the initial stage you're trying to get the tumor out. Alongside, you have anti-androgen therapies. Once the disease becomes resistant to the anti-androgen, then you use abiraterone and prednisolone along with enzalutamide. Recently, docetaxel, which I talked about last time, has become the first chemotherapeutic agent that people are using to control this tumor. And beyond that, we have a lot of different trials and for multiple chemotherapeutic agents that are successful in other tumors, and they're being tried out against prostate cancer. So what's coming over the next 5 years? And why are we looking so actively for it? Well, the reason we're looking actively for it is metastatic prostate cancer is still the biggest cause of cancer-related deaths. It's about 20% of cancer-related deaths are caused in men are caused by prostate adenocarcinoma, which has spread outside the prostate. And despite the advances, our advances have so far been very successful in slowing down the disease, but we don't have anything remotely resembling a cure. So once it's spread outside the prostate, basically we're controlling it. So I'm going to talk to you about 3 different areas that have become recently a bigger priority and is showing progress. And the first one of them is this drug. So it's darolutamide, which is similar to the other drugs which work as androgen receptor antagonist. So you can see over there, within the cell, this drug blocks the effect of testosterone and hence DHT on the prostate cancer cell. So this drug was discovered in the lab within kind of a petri dish environment, and they found that it binds very well to the target compared to the existing line of drugs. So they decided to check it in vivo, meaning inside mouse models, to see whether it binds very well to the receptor as well, and they found that it did. So in competitive binding assays, so when they were comparing the drugs which are the mainstay right now, like enzalutamide, they compared this and darolutamide. They found that darolutamide binds a lot better and much tighter. And they also found that in testing in human patients, they found that it has a lot less CNS toxicity. So anyone who's used enzalutamide knows that one of the limiting factors of using that drug, which is used all over for prostate cancer right now, is the fatigue and the loss of cognitive function. So here we have something which it's got 3 advantages. One, it's binding a lot tighter. So the tighter it binds, the less likely that the hormone can access the receptor. So it's a very tight binder. The second thing is, it is actually causing less side effects, which is usually unknown. Usually you have the other way around. The better a drug works, the more side effects you get. So this actually is working better by giving less side effects because it just doesn't penetrate the blood-brain barrier so well. So because it doesn't get into the brain area, it's not causing those side effects. And the third advantage, which is really unique with this one, is the reason enzalutamide stops working after some time is because there is a mutation in the receptor. So prostate cancer, when it's trying to access the hormones, it has a receptor, and that's what we're trying to block, and that receptor mutates. So now, very often it can mutate to a point where it still binds the hormone, but doesn't bind the drug that is trying to block it. So that that's the main reason, main mechanism through which it escapes. So the prostate cancer escapes the drug by mutating the receptor. Darolutamide is better than enzalutamide because it binds not only the regular receptor, which is there on prostate cells, regular prostate cells, and the beginning stages of prostate cancer cells, but it also binds the mutated versions of the prostate for the androgen receptor. So the way prostate cancer normally escapes enzalutamide, it cannot escape darolutamide. So they had these 3 key pieces of data. So that was promising: less side effects, better binding, and binding even the mutated receptor. So they did this phase 2 study, and they found that this drug was extremely well tolerated. And on this chart here, these are individual patients. Each of these bars represents the individual patients. Everyone here knows the significance of PSA levels? Yeah? Nobody knows what PSA is? No, everybody knows. Okay. So that is the drop in PSA. So actually the first 2 patients were the only 2 patients that did not have a drop in PSA levels, and this is in, I'm going to say 3 weeks. This is in 3 weeks after the drug, and you can see that most patients had a very good drop in PSA levels very quickly after this drug. Some patients exhibiting almost 100% drop within 3 weeks. So that was the phase 2 data. You know, when you have the phase 2 data, they're basically looking for tolerance, and they test different drug doses, and this was the most effective drug dose that worked. And very recently, in March 28, 2019, they released the phase 3 data. And this was done with 437 primary endpoints. And what they were looking for is metastasis-free survival. And the metastasis-free survival was 40.4 months with darolutamide compared with 18.4 months with placebo. Now the placebo here is not really a placebo. We were not giving these patients nothing. It was the regular anti-androgen therapy, and in this case they had added darolutamide. So the addition of darolutamide is what they're calling placebo. Very often you hear of placebo in these clinical trials, and it basically means most of the times it would mean the standard of care. So what is accepted as the best treatment is the placebo treatment. And then on the other side you have that. And rarely in some cases of stage 4 where the best modality of treatment is to do nothing, that's where a placebo would be a real placebo. So here you can see again from the same journal, which came out late in March, you can see the survival rate, and the endpoint, primary endpoint was distant metastasis. So they were monitoring this by PSA levels, and whenever they had higher PSA levels, they were looking for any distant metastasis. And there's a very remarkable difference. You're basically adding 32 months in the time when this disease is making a progress. So darolutamide became such a big thing after this that they've started recruiting for other trials already. And they basically, it makes sense. They're doing a second trial with darolutamide. I think this one is designed just to get more data on what dose is more effective. And then the next one is ADT plus docetaxel, which we know is a chemotherapeutic agent, and darolutamide. So the idea is if you hit it with docetaxel and darolutamide earlier on, does that improve the overall survival versus doing docetaxel first and then darolutamide, or vice versa? So combining the two earlier on, whether that promotes better survival or not. Now with a lot of these drugs, you have to wait a long time before they come to the market. But with darolutamide, we've got the first indications that this is on its way. So it was approved on July 30th. After that data came out, it was so overwhelming that it's a very quick transition between getting the stage 3 data and the approval. And so it's already been approved in the United States. So the hope is that this will definitely become something of a mainstay treatment and will come to Canada soon. So the next thing I want to talk to you about is Xofigo. This is one of those drugs which is actually being used extensively in United States and some parts of Canada because not all provinces approve this so far. And there's some excellent results obtained with this drug, Radium 223. And the reason they use it is for bone metastasis. Anybody who has prostate cancer and the related bone metastasis, this works really well. And the key indication to use it is if the person has bone metastasis, but no visceral metastasis. If it's not gone in any organ that you know of, that the doctor knows of, it can be used, and it works really well for that. And the person who done the most amount of studies on it, Dr. Evan Yu, he believes that it can add to 2 years of progression-free survival. So that's a big deal with this drug. It is not approved yet in Alberta or New Brunswick, Newfoundland, Nova Scotia, Prince Edward Island, Northwest Territories or Yukon. It's approved in the other 5 provinces. And the reason I want to talk about this is based on the more recent studies, it seems more likely that it will come to Alberta. And also I want to talk about what the other studies are indicating that this can be used for. So we know that Xofigo basically goes into it's a radium 223, it's a radioactive treatment. When administered orally, I'm not sure it's orally now, I'm thinking it's intravenously. It essentially goes into the cancer cells, and with the radioactivity, it kills them. So we know that. What they found recently with this is that not only the ones that die, the prostate cancer cells that don't die also divide less. Again, that's logical. The ones that are not killed still get some kind of a radiation. They're not able to divide that well. Again, this should be logically concluded. But what was surprising is those prostate cancer cells that did not die also became sensitive to the immune system killing them. So in these recent papers that are coming out, they're showing that when you expose these prostate cancer cells to radium 223, they become distinguishable from self. One of the reasons the immune system does not attack prostate cancer cells is because it has a hard time distinguishing between self and non-self, right? So, but the exposure of the radiation changes a cell enough that the T cells now start killing it more effectively. So this is a very big thing because essentially you can then combine different kinds of treatments, and you can combine different types of treatments. And so once they found this out, immediately, this was the third paper which had information on this. They've started combining these trials, and I think these next bunch of trials, if any of them show promise, which I think they will, Xofigo will likely be used on a much wider scale and hopefully come to Alberta in the process. So what are these trials that they're doing? They're combining radium 223, which is Xofigo, with olaparib and niraparib. These are PARP inhibitors, and what they're using is PARP inhibitors work very well in certain kind of cancers which are the result of mutations. So anyone who has the BRCA1 or BRCA2 genes and they have the associated prostate cancer related to that, these PARP inhibitors work really well with that. So they're thinking that if we can combine this with radium 223, which makes these cells more vulnerable to T cell killing, the immune system killing, it's likely going to work really well. So those are the first 2 trials. The third and the fourth trials are to do with PD-1 and PD-L1. PD-1 and PD-L1 are probably, there's not a single cancer in which they've not been tried because they're the first immune system drugs that have been discovered, and they basically takes the gloves off the immune system. So you take off the shackles and the immune system goes wild and starts attacking any cell that it thinks is remotely hostile. And cancer cells kind of fit in that remotely hostile thing where they're being evaded, they're evading the immune system. So PD-L1 and PD-1 antibodies work really well for activating the immune system. So that makes sense that you combine it with radium-223, which also increases the T cells to kill the prostate cancer cells. And finally, Sipuleucel T. You guys have heard of Provenge? Provenge? Yeah. So Provenge is a treatment which came out by Dendreon, and it works really well. It has very few side effects. It's basically, the thing is, it's a mechanism with which they take the T cells out of the body, they activate them, your own T cells, they activate them with an antigen against prostate cancer, and they put them back inside. And the resulting treatment is very well tolerated, but it's extremely expensive. Last I heard, the cost was around $100,000 for the treatment. So it's one of the more expensive ones. It works well, but it's not a cure by any standard. Again, they want to see if you combine it with something that naturally increases the vulnerability of those prostate cancer cells, what will be the result? Finally, the third thing I'm going to talk to you about is this new novel molecule. Well, the molecule is not novel, just what we're being able to do with it seems to be novel, is the PSMA, which is Prostate Specific Membrane Antigen. And this is one, we have prostate specific antigen, which is what everybody knows, which is PSA. This is, and that's found in urine, and we can use that to monitor the levels of prostate cancer activity within the body. PSMA plays a key role in keeping the prostate cancer cells stable. And we think that it is a mechanism by which it's helping the prostate cancer survive. It's almost approximately 70 to 90% of prostate cancer patients have this molecule contributing to the survival of the prostate cancer cells. So a very large variety of patients are applicable for this. So what they did find, they've done a few different studies with it. First thing that they found recently was that PSMA levels vary within patients. So if you take a bunch of prostate cancer patients and you look at the PSMA levels, their levels vary. The ones with the highest levels of PSMA also tend to have the worst kinds of prostate cancer. They're more likely to be metastatic. So that's how they basically found that it works in kind of as a survival mechanism. So what they've recently been able to do is target this molecule with antibodies, and they've been able to conjugate a lot of different toxins to the antibodies. So because this molecule is so specific that it's not expressed anywhere else, the antibodies become really specific. So they bind to this molecule, they're taken up within the prostate cancer cell, and then the toxin kills that cell. So they're able to do that. So we just, I think it was a couple of weeks back, we got the first phase 1 studies on this one. And within a few weeks, they were able to get a 15% decrease of PSA levels. Now, these studies were done in people where everything else had been tried. So the prostate cancer cells in this group was incredibly refractory to any treatments that we had. And we've tried everything on them. So in that group, to get a 15% reduction so quickly with PSMA antibodies was quite significant. They've also found now that how can we figure out, without looking, which kind of people would express more PSMA? So the easy way initially is if a person has prostate cancer, you can remove the prostate cancer out and look at the PSMA levels at that point. But beyond that, once it has spread elsewhere and the initial prostate is out, it's hard to kind of determine what the PSMA levels are on the individual prostate cancer cells. So they also did find a gene which is associated with high levels of expression. And in those patients, we think that these antibody treatments will be incredibly effective because they have 4 times as much PSMA on the surface. And then, the antibodies are definitely going to bind and get taken up, and the toxins are going to kill the prostate cancer cells. Beyond that, they're also using PSMA for imaging. Now that they found this antibody, they're also trying to use it to detect where the prostate cancer cells might be hiding. Because now that you have this antibody, scientists have got all kinds of tricks. Basically, you can bind a lot of different things to one antibody. So you can bind something that gives a radioactive tag. You can bind something that gives a fluorescent tag. So there's a lot of different things you can tag onto the antibody once you have something that's that specific. And so then you can image it. So you can see where the prostate cancer cells are hiding and what the burden is right now in the body. So PSMA is also being used for imaging, and that's one of the trials that just recently started. And it's going to be used to figure out how we can use it for imaging and figuring out the tumor burden in the body. So to sum up the 3 different treatments that I talked about today, darolutamide has been approved in US, and it is a fantastic drug in terms of being more than twice as effective in terms of progression-free survival, and it also produces less than half the symptoms in the CNS at least. So the hope is, since the idea was to talk about stuff that's going to be here in the next 5 years, I think this is definitely going to be one of the drugs that's going to be here and approved. There's no reason why it wouldn't be over enzalutamide and the other ones we have right now. Radium 223 Xofigo is likely to be way more potent than we thought because it activates the immune cells and makes the immune cells kill the prostate cancer cells more effectively. So now combining Xofigo and immunotherapy, as I mentioned, there are 5 trials already on, and I think that could be the push to get it approved for various treatments within Alberta and widen its range. PSMA is now becoming the best target for search and destroy kind of drugs because it's very specific to prostate cancer cells. We can use antibodies that are very specific and bind there. And we also know now how to find out, and that was a recent July paper, how to find out patients that will express large amounts of this antibody on the prostate cancer cell. So we can identify the group of patients who will most benefit from it. And in that group, I think PSMA antibodies will have a great impact in the next few years. And so that is it. Questions?
I think darolutamide, what I understand from Dr. Ruther's, probably 2 or 3 years away at best before funding gets approved here. So we've got quite a long road before we get there. Darolutamide probably going to come first, but darolutamide is behind that. Is that your understanding as well?
As far as the funding specifically, no, I don't have that much visual into it. You probably know more about it than I do. I think if you look at the general timeline between getting approval in the United States and something coming to Canada, it is usually about 2 to 3 years. But there have been some cases where the cost is so prohibitive that it's not come at all. And the provinces basically make their own call, dividing it all. Like Xofigo is basically come in half the provinces and the other half don't have it. So I think in this case, the data looks so good, I would be surprised if it takes 3 years.
Right.
So it would save the province, ultimately, even if they do a cost-benefit analysis, this is going to keep so many patients so much healthier for so much longer. It's going to be unless I don't know how they're going to price it, but unless it's priced really prohibitively, I think this will get approved faster, in my opinion. Yes?
It pointed in the way I read it, but I thought I read that on the darolutamide is for metastasized prostate cancer, and they're comparing it to enzalutamide, which is for metastasized prostate cancer. I can't understand. The darolutamide is supposed to be better than enzalutamide. Why didn't it say that it's for metastasized instead of non-metastasized prostate cancer?
Okay. I think I know what you're asking. There are multiple studies being done. I'm not sure we may be referring to the exact same study, but the one which got its approval, the study which got the approval, that one was, the endpoint was metastasis-free survival. So it was definitely done in patients who had no metastasis at the point. So in that study, it was done in that case. Yes, it will likely be used for people with metastasis and no metastasis, so all of them. And enzalutamide is used for people with metastasis. But the endpoint of the study which got it approval was after extraction of the primary tumor, they were looking to see how long until there is metastasis. So that's the study that got it approved. I'm sure there are multiple others being done, and you might have read something where it's pitched up against enzalutamide in post-metastatic setting, which is highly possible. And it'll work there too, probably better than enzalutamide. Because we know the mechanism by which it's working. It's basically doing everything enzalutamide is doing, it's doing it much better. So it will work in that setting as well, and it'll work better than that. Yes.
Well, I have been taking enzalutamide, and I had micrometastatic, but not metastatic disease in terms of radiographic evidence. And enzalutamide, which is now fading for me, will be 6 years this fall. So it's a long time that it has worked for me before it finally faded, or starting to fade, materially fading. So it's, I believe you don't need to have metastatic disease in order to be prescribed enzalutamide or extending.
Oh, absolutely not. Maybe I wasn't clear on that. The study was looking, the end point of the study, meaning when do we say that a patient is out of the study? That's what I mean by the end point of the study. So the study which got it approval, let me see if we can get back to the slide. The study which got it approved, the primary endpoint was metastasis-free survival. Now that means the moment we detect a metastasis by rising PSA levels and confirm that there's a metastasis, that person goes out of the study and that line drops a little bit. So there's a patient who's got metastasis. So this study was done with patients who had the primary tumor resected, and then they were put on darolutamide or enzalutamide, and So yes, it is used in a metastatic setting. It is used when there is no metastasis, and that's kind of interchangeable. But for studying purposes, the group was synchronized with this, so we know it works better than the standard treatment. And you're seeing 19 months, in darolutamide 40 months, and that's the median. There are patients who may go for 10 years on this eventually. And same, I'm really happy it's worked for you, enzalutamide, so well. Hopefully it works for a lot of other patients as well. But the data suggests that darolutamide will be better. So if somebody's getting 6 years out of enzalutamide, they may get 10 years out of this one. Yes.
I have a two-part question. The first part, do you have any idea of why Alberta has been dragging its heels in terms of the approval of Radium-223 when virtually all of the other provinces, from BC all the way through Ontario, and Saskatchewan, Manitoba, BC, have had it approved. I mean, 2 years ago, it was only BC and Ontario. Now I see Saskatchewan's approved it in Manitoba. So again, my question, why Is Alberta been dragging its heels?
I think it's always a cost-benefit analysis, but I wouldn't be so quick to just single out Alberta in that. And I know you, I mean, there's a lot of provinces in Alberta's boat last I checked. So they're not the only one that's dragging on that one. So, you know, I think in each case it's a cost-benefit analysis, and unfortunately, they have limited dollars that they try to spend. And
Saskatchewan does a cost-benefit analysis, out does Manitoba, BC, every province does.
I think a lot of these things are,
We into new accounting here in Alberta.
I think it is, if you go to see what's the standard of care is in each province, it's slightly different. So you have to understand that there are many multiple factors that go into it. One, what is their bulk purchasing power? A province like Ontario, which is purchasing a lot more than a province like Prince Edward Island, is obviously going to have, you know, be able to get a lower price in some cases. So one is what is their purchasing level. Second is what is their approved treatment. So they're always comparing against what drugs they've already approved. And it's not always the same. All the other drugs are different. And what Radium. So the cost-benefit analysis is run against that. And it's subjective ultimately. A lot of these things, I mean, what do you use? You know, sometimes there are 5 or 6 different studies which show that things will be better. Okay, so which one of those studies do you use? And different people are using different studies to make the decision. One says it's 36 months, the other says it's 40 months. Those things can sway the decision quite a lot in the cost-benefit analysis. So.
Second part of the question. Do you know whether or not it's possible for anyone living in Alberta who may want to consider this treatment to be able to go to a neighboring province and get the treatment at cost?
You pay for it?
Yeah.
I think that would be possible, right? Brad, do you know anything about this? You've been
I don't
involved
know
with this
for
a
a
lot longer.
fact, no, whether or not the big issue is if Alberta hasn't approved it, then they're not paying for it, so you're on your own. But I know other treatments where gentlemen have gone to outside the country and paid for it and received treatment, so.
Yeah,
I can answer that question. I was recently in Vancouver with BC Cancer Board there, and I asked that question. And as an out-of-province patient, if I was willing to pay, they would treat me with Radium-223, about 20,000 a shot. The cheaper way of doing it is to move to BC. And I looked at that and asked them those questions, and you'd have to move and be there 3 months before you could go and access their medical health plan.
Yeah.
Just like when you move from one province to another, you'd have to establish.
That is wonderful knowledge. Thank you for sharing.
Establish a residence for 6 months and a day, and you'd have to change a lot of other things that you do, and you lose the access to your medical oncologist in Calgary, and you would obtain a new one in Kelowna or wherever you were. And
Brad, nobody's going to show up at the next meeting.
was something I was thinking about, but haven't gone there yet.
Well, that's wonderful to know that that works like that. I didn't know that you could do that. Thought it would be. You can move.
I know that, Radium-223, you can get it across the border. I mean, you can get anything across the border if you're willing to pay for it.
It's 3 hours drive, right?
But we're talking about, the Canadian medical communities and different provinces and so on.
Well, maybe they'll standardize it at some point. But right now, the fractures are just growing deeper as far as I can see between these treatments. 'Cause there's so many of them and they're very, very expensive. You look at the margins on the biotech drugs that are there, it's crazy the amount of money these people make. I know that goes into the research and everything, but it's a huge cost. So it's mind-boggling. Yes.
In your research and your studies and reading, have you seen any studies where they're looking at apalutamide versus darolutamide? both being so new?
No, I don't think those two have been pitched
No,
against
I
each other.
haven't seen
No.
anything either. It's all apalutamide and existing.
They've done those studies in vitro, binding assays in vitro, not inside patients. Inside a petri dish.
Yeah.
And inside a petri dish, darolutamide is probably better. If that translates into what happens inside the body, darolutamide is going to win.
Yeah. Yeah, I'm just wondering, with apalutamide being that much further in darolutamide, is it going to replace apalutamide? In your opinion?
I think it may come down to CNS toxicity. For a lot of patients who, with apalutamide, if they're still experiencing CNS toxicity, because darolutamide's profile will be better just because of the blood-brain barrier penetration. So just in terms of quality of life, it may beat apalutamide. Brad's not satisfied with that answer. He's looking at me like, I need more. Yes?
One of the most recent treatment, I think in several cancers, that apparently has been successful, is the immunotherapy,
Yes.
the immune system. For example, the most famous case is patient Carter that has cancer in the brain, and using this approach, is cured practically. Then, well, do you see in your study any attempt to apply this system, immunotreatment, to the prostate cancer treatment?
Sorry, I didn't get the last part.
Yes. If in the treatment of prostate cancer,
Yeah.
have you found any development in applying immunotreatments?
Well, the PSMA treatment would be form of an immunotreatment, right? Because you'd be using, well, let's take a step back. The Xofigo is basically working like an immunotreatment because you're activating the T cells, and then the T cells are going to kill the prostate cancer cells. But if you look at all the trials that are taking place over here, the last 3 trials basically are using the immune system. So pembrolizumab, which is a PD-1 antibody, the other one which is a PD-L1 antibody, and sipuleucel T, they're all trying to activate the T cells, right? The way the prostate cancer is blocking the T cells is there's a PD-1, PD-L1 binding, so the prostate cancer and the T cells are interacting, and this is basically telling you, stop, I'm a friend of the body, right? And that's the reason the T cell moves on to trying to find another target. So when you block that interaction with an antibody so that the T cell and the prostate cancer cell cannot bind to each other, and basically the prostate cancer cannot tell it that everything is okay, then the T cell will go and kill that prostate cancer cell. So the Radium 223 trials, the last 3 trials are essentially immune treatments. Though I might have not framed it like that, they are immunotherapies. The PSMA, which is a prostate specific antibody, so essentially the way they're going to use it is that antibody is going to bind that. Now antibodies, people don't necessarily think of them as immune treatments, but they are immune treatments. It's, in a normal healthy person, the B cell produces antibodies and that binds to viruses, and that's how you get rid of your cold. So in this case, it'll be an artificial antibody from the outside, but the antibody will bind to that PSMA, and then the prostate cancer will take it up inside. Now we are going to sneakily put a toxin at the back of that antibody. So with that antibody taken inside, the toxin will kill the PSMA. And the reason we can use extremely toxic substances for this kind of treatment is because antibodies are very specific. They don't bind anything else. So the antibody will bind only that PSMA, and while that toxin is bound to that antibody, it remains inert. Once it's taken up inside, and the prostate cancer cell will nicely do the work for us and digest the antibody, and then the toxin will kill it. So that's again an immunotherapy. I mean, it may not be labeled exactly as that, but using an antibody to me is an immunotherapy.